In this video, we are going to see about the applied anatomy of the ulnar nerve. What are the features that are seen in ulnar nerve injury and how the ulnar nerve can be tested. So this is a gross overview of the supply of the ulnar nerve. The ulnar nerve supplies only two muscles of the forearm. To be precise, 1.5 muscle of the forearm being the flexor carpi ulnaris and medial half of flexor digitorum profundus, and most of the intrinsic muscles of the hand, that is the palmaris brevis, the hypothenar muscles, the abductor digiti minimi, opponens digiti minimi, flexor digiti minimi, all the palmar interossei, all the dorsal interossei, third and fourth lumbricals, and two thenar muscles, that is the adductor pollicis and the deep head of the flexor pollicis brevis as well. And it has its sensory supply over the medial surface of the palm as well as the medial 1.5 fingers on the palmar aspect as well as on the dorsal aspect. Injury to the ulnar nerve will cause the claw hand deformity. So let us see in detail. So these injuries to the ulnar nerve can occur at the elbow and at the wrist. So the injury at the elbow or nearer to the elbow may be because of the fracture or dislocation of the medial epicondyle or fracture of the upper part of the ulna, that is onto the olecranian process, thickening of the fibrous roof of the cubital tunnel, and the compression of the nerve between the two heads of the flexor carpi ulnaris muscle, and there can be a valgus defect at the elbow which decreases the carrying angle, which leads to a late ulnar nerve palsy. Can be due to penetrating wounds and gunshot wounds also. And the injuries at the wrist can be because of the wrist lacerations or cut wounds like suicidal cuts, and compression in the Guyon's canal or pisohamate canal can be due to fracture of carpal bones or malunion of Colles fracture and the usage of tight handcuffs. If we see the features of ulnar nerve injury at the elbow, which is due to these factors which we just now said are the fracture and dislocation of the medial epicondyle and upper end of the ulna as well, cubital tunnel syndrome, compression between the two heads of flexor carpi ulnaris, and valgus deformity where the carrying angle is increased. So the characteristic clinical features which are noticed are mainly the atrophy and flattening of the hypothenar eminence because of the paralysis of the hypothenar muscles, which are the abductor digiti minimi, flexor digiti minimi, and opponens digiti minimi. And there is claw hand deformity that is seen where there is extension at the metacarpophalangeal joints and flexion at interphalangeal joints, which is due to the paralysis of the lumbrical muscles, which are the third and fourth lumbricals. And this claw hand deformity is more exaggerated or pronounced when the injury is nearer to the wrist, where the flexion at the terminal phalanx is more, which is known as ulnar paradox, and is due to the unopposed action of flexor digitorum profundus. And there is loss of abduction and adduction of the fingers because of the paralysis of all the interossei, which are the palmar and dorsal interossei. Because of the paralysis of the interossei, there is atrophy that is seen on the dorsum of the hand between the extensor tendons. You can see this is the normal hand on the dorsum. This is where you can see the interossei which are atrophied, and the flattening is seen here on the dorsum of the hand. And there is loss of adduction of the thumb because of the paralysis of adductor pollicis as well. And here you can see the loss of sensation of the palm on the palmar and the dorsal surfaces, and also medial 1.5 fingers on the palmar aspect and on the dorsal side. And there is weakening or decrease in the grip strength because of the paralysis of the palmaris brevis. There is clumsiness of the movements of the hand that are seen. The fine and prehensile movements are lost because of the paralysis of most of these intrinsic muscles. And pain, numbness and tingling is because of the sensory loss. So these are all the signs and symptoms that are seen when the ulnar nerve is injured at elbow. And the foment sign is positive. We will see what the foment sign is in the later part of the video. So these are the reasons where the ulnar nerve can get injured at the elbow. So this is the fracture of the medial epicondyle. This is the cubitus valgus, where the carrying angle is increased, leading to the pull on the ulnar nerve, thus compressing it. And the ulnar nerve can also get compressed at the cubital tunnel, which may be one of the features causing it is anconeus epitrochlearis, which is an extra muscle in the extensor compartment of the elbow or the forearm there, which is analogous to the obsons band, this one, which is attached to the medial epicondyle and the olecranian process. So if this obsons band is present, the anconeus epitrochlearis is not present, and if this is present, the obsons band is not present. And this ulnar nerve can get compressed by arcade of Struthers as well, and it gets compressed as it passes between the two heads of the flexor carpi ulnaris. And this is what is the fracture of the upper end of the ulna, where the ulnar nerve, which is related posteriorly, can get damaged. And here see, when there is incorrect posture and repetitive flexion of the elbow or constant strain, usually seen with cell phone users, which is called as cell phone elbow, where there is strain on the ulnar nerve and can cause compression as well as the stretching of the ulnar nerve here because of this constant strain at the elbow. Now let us see the features that are seen when the ulnar nerve is injured at wrist. So the superficial position of the ulnar nerve at this site here makes it vulnerable to cuts, that is the suicidal cuts in forensic language. which has a medico-legal importance there, and compression at the Guyon's canal or pisohamate canal. If we look into the clinical features that are seen with the ulnar nerve injury at the wrist are all the same when the ulnar nerve is injured at elbow, except for the ulnar nerve paradox, where the flexor digitorum profundus is not paralyzed, the medial half, where its tendons are going to the ring and little finger. Because of the functioning of the flexor digitorum profundus, there is marked flexion associated with already flexed distal interphalangeal joints because of the paralysis of lumbricals and unopposed action of the flexor digitorum profundus. So there is pronounced claw hand that is seen when the ulnar nerve is injured at the wrist, which is called as ulnar paradox. Along with that, there is atrophy, flattening of the hypothenar eminence, there is loss of abduction, adduction of the fingers, and there is flattening and atrophy of the back of the hand, that is on the dorsum of the hand, because of the atrophy of the interossei. And these features can be due to many reasons, one of which mainly is the compression of the ulnar nerve within the Guyon's canal, and it is also due to handlebar palsy, where it is mostly seen in the cyclists who perform in the racing, where the hand is held on the medial aspect of the wrist for a longer time, compressing the hypothenar eminence, in turn compressing the ulnar nerve. It is also seen in workers who work with a large, very huge hammer, which is called as hypothenar hammer syndrome, where you can see here the handle of the hammer, which is held against the hypothenar eminence for a longer time, compresses the hypothenar eminence, in turn the ulnar nerve. Can be seen in occupational neuritis as well, where the compression of the ulnar nerve is seen in cubital tunnel due to its repetitive compression at the edge of the desk surface, and can be due to compression of the ulnar nerve in the Guyon's canal, that is at the wrist, because of the same reason of repetitive compression during the work hours. Can be due to the fracture of the carpals, more so the lunate fracture, where the compression of the ulnar nerve is seen. Can be seen in Colles and Smith's fracture as well, where the lower end of the forearm or there is fracture at the wrist that is seen, and usually seen in the Colles fracture mall union as well, where there is pull of the ulnar nerve where it can get compressed. These are the cut wounds, the lacerated wounds at the wrist, and can be seen with tight hand bands or handcuffs compressing the ulnar nerve at the wrist, that is at the Guyon's canal. So what is this claw hand? So this claw hand can be seen when the ulnar nerve is injured at the elbow, that is behind the medial epicondyle, in the cubital canal or cubital tunnel, and it can be injured at the wrist, that is at the Quion's canal, which can cause this claw hand. So the effect of the lesion at wrist, it produces the claw hand as a main feature, which is due to the paralysis of third and fourth lumbricals, where there is hyperextension that is seen at metacarpophalangeal joints and flexion at interphalangeal joints. So normally the normal function of the lumbrical is the flexion at metacarpophalangeal joint and extension at interphalangeal joint. So when the lumbricals are paralyzed, there is hyperextension at the metacarpophalangeal joint because of the unopposed actions of the extensor tendons also, and there is flexion at interphalangeal joints, and there is paralysis of palmar and the dorsal interossei. With the palmar interossei, there is inability of adduction of the fingers, the middle finger being the axis of the hand. The fingers can't move towards the middle finger, so the adduction of the fingers are lost because of paralysis of the palmar interossei, because of the paralysis of the dorsal interossei, which are all bipinnate. There is inability to abduct the fingers away from the middle finger. So there is also sensory loss that is seen over the medial half of the palm and medial 1.5 fingers on the palmar aspect as well as on the dorsal aspect because of the injury to the palmar cutaneous nerve, the superficial branch of the ulnar nerve, and the dorsal cutaneous nerve of the ulnar. So there is loss of sympathetic supply also because of the contribution from T1 root. So the vasomotor changes are also seen in the medial 1.5 fingers, where there is drying of the skin, scaling of the skin, that is all seen, and this is what is the claw hand that is seen. Because of the unopposed action of long flexors and extensors, there is hyperextension of the metacarpophalangeal joints and flexion at the interphalangeal joints. So the claw hand can be your short notes. Other reasons of the ulnar nerve being compressed or getting injured is subluxation. That is, this is the normal course of the ulnar nerve which goes behind the medial epicondyle. So there is all possibility of this ulnar nerve getting slipped from its normal position, causing tingling sensation and pain like pins and needles pain that is seen over the supply of the ulnar nerve, that is mainly onto the palm, the medial half of the palmar surface and dorsal surface of the palm and medial 1.5 fingers. So what they do is they cut the heads of the flexor carpi ulnaris, move the ulnar nerve in front, that is the ulnar nerve as transposed in front, and they are again sutured, keeping the ulnar nerve in its place. So the ulnar nerve is transpositioned from its original course, which is behind the medial epicondyle, which can also be done due to the ulnar nerve compression in the cubital tunnel here behind the medial epicondyle. So this is how the ulnar nerve is transpositioned anteriorly and is kept in position. So this is how the wasting of the dorsum of the hand is seen because of the wasting atrophy of the palmar and dorsal interossea. One more most important thing is to differentiate between the medial claw hand and the ulnar claw hand. So first let us see the ulnar claw hand. When the injury to the ulnar nerve is more proximal, that is nearer the elbow, they can't flex the fourth and fifth fingers when a person is asked to make a fist. That is because of the loss of the function of flexor digitorum profundus. But there can be slight flexion that is seen in the third and fourth interphalangeal joints and extension at the metacarpophalangeal joints, but the person will not be able to make a proper fist. There is extension of these, the ring and the little fingers. And if the injury is more distal, that is nearer to the wrist, the claw hand is more pronounced. So when the person is asked to extend all the fingers, the person with the injury to the ulnar nerve at the wrist will not be able to extend the ring and middle fingers because of the loss of the lumbrical function. So is the reason there is extension of the metacarpophalangeal joints and flexion at the interphalangeal joints, and which is more pronounced because of the unopposed action of the flexor digitorum profundus as well. So this is what is the claw hand, and this is what is the ulnar paradox that is seen. So when we look at the median nerve injury proximally, and when the patient is asked to make a fist, that person will not be able to flex the index and the middle fingers for the same reason of the loss of the function of flexor digitorum profundus. Here, more distally, if the median nerve is injured, the clawing is more pronounced because of the loss of the lumbrical action. So this is what is the main differentiation between the ulnar claw hand, where the clawing is seen in the ring and the little fingers. For the median claw hand, the clawing is seen in the index and the middle fingers, and for the ulnar claw hand, that way may be due to the compression of the ulnar nerve in the Guillaume's canal, which may be due to various reasons what we have just seen. And here the compression of the median nerve is in the carpal tunnel, and this is how the clawing is seen, which is more pronounced for the ring and the little fingers, and there is atrophy of the web spaces here you can see, which are due to the atrophy of the dorsal and palmar interossea. So this is what is the clawing, where the explanation goes is because of the unopposed flexor digitorum profundus muscles which are acting on the distal interphalangeal joints, causing them flexion at that place, and the extension of the metacarpophalangeal joint and the flexion at interphalangeal joint, is due to the loss of function of the lumbricals as well as unopposed action of the extensor digitorum muscles as well. So how do we test the ulnar nerve? As we all know by now that the ulnar nerve supplies the 1.5 muscles in the forearm and most of the muscles of the hand. And also it gives a dorsal cutaneous branch and palmar cutaneous branch and superficial ulnar nerve, which is supplying the cutaneous supply to the medial half of the hand and medial 1.5 fingers. So to test the flexor carpi ulnaris, the patient is asked to flex the wrist onto the ulnar side against resistance. And to test the flexor digitorum profundus, the patient is asked to flex the terminal phalanx of the little finger against resistance. And to test the palmar and dorsal cutaneous branch, the sensations, if there is pain, numbness and tingling sensations that are experienced on the hypothenar eminence and medial half of the palm and medial 1.5 fingers on the palmar and dorsal aspect, they can be tested for the functioning of the cutaneous nerves, which are the branches of the ulnar nerve. So when the nerve here is stabbed behind the medial epicondyle because it is subcutaneous there, or if it is stabbed somewhere at the wrist, just proximal to the wrist, then there is tingling sensation and pain and numbness that is felt in the medial half of the hand and medial 1.5 fingers, having pins and needle sensation along the ulnar nerve supply, which is called as Tinel sign. If the numbness, tingling sensations and pins and needles sort of pain is felt, then the Tinel sign is said to be positive. There is another test when the person is asked to adduct the fingers, keeping his hand flat on a table. He will not be able to adduct the little finger, which is called as Swartenberg sign. The adduction of the little finger is not possible because of the paralysis of the palmar interossei. Coming to the foment sign, when a patient is asked to hold a paper between the index and thumb as a lateral pinch grip and tightly, and the doctor, if he pulls the patient, there is hyperflexion of the interphalangeal joint of the thumb due to the unopposed action of the flexor pollicis longus to keep the paper in position, because there is loss of the function of adductor pollicis and the interossei. So if there is hyperflexion as the paper is pulled from the patient's hand, it denotes positive foment sign. And there's another test which is called as phalanx test, where the patient is asked to raise his hands to the the shoulder level and flex the wrists and approximate the dorsum of both the hands and keep in the same position for about 30 to 60 seconds, that's 1 minute. Then the patient can experience the tingling and numbness, pins and needle sensation and paresthesia that is seen in 4th and 5th finger, that is the medial 1.5 finger and medial half of the hand. So these are all the tests that are done to confirm that the injury is to the ulnar nerve. And there are few more tests where the patient is asked to hold the paper in between any of the fingers and is pulled. If the patient can hold back the paper, then the palmar interossei are functioning, which in turn tells the adduction of the fingers is properly functioning, which tests the palmar interossei. And to test the dorsal interossei, the abduction of the fingers is seen against resistance, which will tell about the functioning of the dorsal interossei. Cross finger test, where the patient is asked to cross the finger, the index finger, over the middle finger, over and below the middle finger, to test the adduction of the index finger, where it represents the functioning of the palmar interossei. The patient is asked to hold the cards in this way, where the flexion is at the metacarpophalangeal joint and extension at the interphalangeal joints. If he fails to hold this and there is any deformity that is seen in the medial 1.5 finger, that is the ring and the little finger, where the flexion of the metacarpophalangeal joints is not seen and the extension of the interphalangeal joints is not seen, then it represents the ulnar nerve palsy, as third and fourth lumbricals are not functioning. So have a great day.